Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
Disclosures for this podcast are listed on the podcast page. Hello, and welcome to this two-part episode of the ASCO Education podcast. Today, we will explore some real-time and real-world issues that oncologists face while practicing in rural areas in the U.S. and abroad. I'm Dr. Jack Hensold, a hematologist oncologist in Bozeman, Montana, and chair of the ASCO Rural Cancer Care Task Force. I also serve as medical director of regional outreach at Bozeman Health. Joining me is Chris Prakash, oncologist and medical director of Texas Oncology and the president of the Texas Society of Clinical Oncology. Chris is also the director of quality services for the statewide group and leads Texas Oncologist Precision Medicine Initiative. Also joining me is Professor Sabe Sabesan, a medical oncologist in regional Australia. He's the president-elect of the Clinical Oncology Society of Australia and the clinical director of the Australian Teledyne Health Program, led by the Queensland State Department of Health. Professor Sabazin is an internationally recognized expert in the area of teleoncology and has developed and evaluated various oncology models to deliver cancer care closer to home. In part one, our guests were explaining what got them into rural practice and the issues they face in patient transportation, telehealth, getting access to the latest information on treatments, and connecting with other colleagues to get insight on patient cases. Here I asked Dr. Prakash about one issue that does not get talked about very often.
I think, we don't talk enough about access to clinical trials for rural population. And that's a hard problem. These are regulated. But I wonder about real world trials. Those are a little easier to do. Maybe we can put more patients on those. The hub and spoke model, that would be helpful in that. And I know people are trying, and many societies are trying to enroll, more rural population in trials, but it continues to be a challenge.
Correct. And actually, ASCO has a workforce right now that's trying to address this problem. That includes patient representatives, as well as, I think, people from the National Cancer Institute and people from the pharmaceutical industry who've been on that task force. And it really is trying to address what are the barriers that keep us from getting trials out to our patients in the rural areas, because it is identified as a real problem. I think, as we all know, excellent cancer care requires access to clinical trials, and limited access means quality of the care is going to be less. Dr. Sabazin, you've been working on improving chemotherapy access in rural parts of Australia. Do you think your programs like telechemotherapy could be implemented in other regions and even in this country, the United States? And can they be applied to clinical trials and teletrials, essentially?
This is where I get really excited, because the use of telemedicine beyond providing consultations and then using it for chemotherapy and clinical trial, actually, that's what keeps me up in the morning and keeps me awake in the night as well. What I see these things as, they are system solutions for a chronic problem. In telechemotherapy, it's simple, really. It's rural nurses. They are not chemotherapy nurses. They are general nurses. They administer selected chemotherapy regimens under the direct supervision of doctors, nurses, and pharmacists from larger centers through telemedicine, telenursing, and telepharmacy. So all we need for telechemotherapy to happen, if you have a larger center willing to supervise a smaller center, or a larger center is now expected to do that through health system directives, then I think we could implement that throughout the system. And what we done in Queensland, we got the Queensland state government to implement that, because we got a governance document called Queensland Remote Chemotherapy Supervision Model and Guide for Implementation. Basically, that articulates how to set up these services safely. But we already published that in Journal of Oncology Practice in 2018. So that was a rewarding experience. But then what we found, we could do immunotherapy infusions, toxic chemotherapy like BEP and all those things in smaller centers, but we couldn't do clinical trials because, as Chris said, it's highly regulated. So then we said, how come you can do toxic intensive chemotherapy but not clinical trials? So that's how the Australian teletrial model was born. So we thought we will use the teletrial model to connect larger centers with smaller centers to create trial clusters so that you can really distribute the clinical trials activity to the regional, rural, and remote areas. So now we have a Australian teletrial model and a national teletrial principles as a government policy to enable that. Through some pilots we published in the Journal of Telemedicine Telecare, the Australian government actually funded 125 million to transform the Australian clinical trial sector as a network and a national system so that patients from regional, remote, and rural areas can access clinical trial or some or all aspects of clinical trials closer to home. So that is exciting because it's about 1 year into the program. Already we could see the narrative is changing, and we are saying clinical trials need to be offered as networks, not as silos anymore because of social justice and equity. So that's been becoming powerful. And also we've been now pushing the ethics committees to mandate that clinical trials need to be done as clusters because it is an ethical social justice issue. So I think if we have good governance and government support, I feel that we can actually implement these models in larger part of the rural sector, not all of them, but in larger parts. But I just wanted to highlight before I finish is that the decentralized trials becoming popular, and I feel like the decentralized trials are kind of hijacking the rural narrative here because this is really, they are not decentralized trials in my observation. They should be decentralized trial systems. And rather than bypassing hospitals and directly dealing with patients at home, in a lot of the trial, it seems that most of those patients are actually metropolitan patients. And I think any decentralized trial systems have to focus on partnerships with rural sectors, capability or capacity building of rural sectors, so that you could really deliver clinical trials in a distributed network system to really fix this problem once and for all.
Sabe, it sounds like there's much that we can learn from paying attention to what's going on in Australia. It seems like your group is well ahead of the curve in terms of what needs to happen in rural areas. Chris, comments about that as well?
Yeah, I was going to say, I think excellent job, Sabe. Kudos to you for doing this in Australia. It's a clinical dilemma. It's an ethical dilemma sometimes. Clinical trials are fundamental to providing good quality care for our patients, right? But American healthcare system is complex. Clinical trials, sad to say, I mean, they're money makers for a lot of big institutions or pharmaceutical companies for sure. So what these companies are looking for, if they have a new drug, they want to get a trial done as quickly as possible, get positive data, and then get it approved. It's really hard to find a good phase 3 randomized placebo-controlled trial anymore. They're just non-existent. They're all phase 1, 2, quick, 1 year, get the data and file for approval with the FDA. So I get your point. I think I would love to have a good trial where we can put patients on, rural patients on, but I don't know if that's going to be possible. Now, what I'm doing in Texas Oncology, I'm the director of quality services. So that is my goal, is to give quality care to the whole state population, right, wherever we can. And clinical trial is the most difficult task I'm finding. I can, make testing consistent. I can make treatment protocols consistent, but getting patients on clinical trials is a very difficult task. So kudos to you, Sabe. You're doing an excellent job.
It's actually the main enabler for us. It's actually the government intervention, because what we felt was the rural sector has been left in the hands of clinicians and local health managers for far too long, but no one was in charge of that gap. So now, by the government's coming to the party and trying to implement some policies and funding mechanisms, things are changing. But really, still, I found the advocacy hasn't stopped. And there's still a long way to go, even in Australia. but it's pure advocacy from rural oncologists like us.
Yeah, I think that kind of highlights the difference in American and Australian healthcare system, probably. American healthcare system is still very private. I mean, we have a big Medicare part of the equation, but again, a lot of healthcare is really delivered by private companies, hospital systems that are for profit, pharmaceutical companies that really have strong lobbying systems. So it's a complex situation here.
Yeah, I would agree with that fully. And that when I was hearing Sabe talk about things and comparing it to our experience in this country, we are very fragmented in terms of our care delivery systems, and trying to get a coordinated approach to how we address this rural health problem is difficult because we're bringing so many different people to the table who all have different points of view in terms of how they look at this. So again, this may be a much harder piece to try to achieve just simply because of the fragmentation of the way we provide care in this country. So, Dr. Prakash, you remember several groups that address the need for rural cancer care in the United States. That includes ASCO's Rural Cancer Care Task Force, as well as the work you do with the Texas Oncology Society. Can you be a little bit more specific about those efforts?
Yeah, thanks, Jack. As you know, I was a member of the ASCO Task Force on Rural Cancer Care. This was put together in 2019, and then the pandemic happened, right? The timing was just right. But, we were tasked with finding and really defining what the challenges of rural cancer care are and what are the solutions that we can come up with. It was a very hard job, but we did come up with some solutions on that, mainly increasing provider education, workforce enhancement. We've talked about a few of these things already, telehealth promotion, and of course, research. But as you know, these solutions are easier said than done, and work continues on these fronts. And thank you, Jack, for taking the lead on many of these issues in the U.S. So currently, as you know, I'm the president of Texas Society of Clinical Oncology, and I'm doing a lot of advocacy work at the state capitol in Austin regarding various bills and provisions, but especially to garner support on a new biomarker bill. So this bill, if passed, will help pay for all biomarker testing in cancer. So, there are disparities and rural disparities in cancer care. So if this bill is passed with the biomarker testing, this may go a long way in removing some of the disparities that our patients face in terms of testing, biomarkers and payment for those tests as well. And I firmly believe that quality of care should be consistent no matter where a patient lives. I'm the director of quality services for Texas Oncology. I'm leading the precision medicine initiative for the state, and I'm developing protocols for consistent biomarker testing, mutational analysis in tumors, and treatment protocols. So efforts continue, and please stay tuned.
Thank you for that and all the work you do, Chris. I think it's an important point and I've been involved through the Montana State Oncology Society, which is our society, in terms of doing advocacy at the state level as well. And I think that's very important, particularly for states that have large rural populations, because I'm not sure nationally people fully understand some of the difficulties that those patients face, and advocating for improved healthcare across the board is critical. And in the rural patient needs to be considered as we think about any changes to how we administer healthcare in this country, the laws that regulate.
You're exactly right. I mean, advocacy is very, very important. And, our congressmen and representatives, they do listen. As a physician, you go and talk to them and express concerns about what the constituents are going through and the hurdles they're facing in their care. They will listen. And, you can make a change. And that's what fascinates me about practicing in rural setting is that I can make a difference. I can see a change. Just over the last 20 years that I've been here, things have changed. Not all for the better, but you can be a part of the whole process.
Yes, I would completely concur. I think our legislators nationally and statewide are very responsive to our voices. If there's something that's impacting their constituents in terms of the care that they're receiving, they're going to want to know about that. And they're happy to look like the champions, I think, to support improving their care. This is something we all can do a better job at nationally. Sabe, not to leave you out of that conversation, any thoughts about that?
I mean, the advocacy is the key. That is also one of our job as doctors. But the main thing about advocacy is actually self-care, I found. As long as we don't burn out and we keep our energy level going and focus on recharging and minimizing energy discharge. We stay strong and take our colleagues with us. I think that's what I learned in advocacy, is to make sure we don't drain our energy in that process.
The quality of care should be the same for every patient, no matter where they live. And that really is kind of one of the driving principles for me in terms of why I got into this rural cancer care task force and the initiatives that we're taking on. And I'd like to describe a project right now that I've undertaken with ASCO and with our local regional health center and a medium-sized hospital in our area. Actually, not in our area, it's 125 miles away, but an area that we service, and patients regularly come to our regional center for their cancer care. I think it was the appreciation that this 250-mile round trip, particularly to receive things like chemotherapy, was just a tremendous burden for patients from that area. And in addition to the problems with the financial aspects of traveling long distances to receive that care, there was also the issue that we were sending patients back to fairly distant sites to experience the toxicities associated with our treatments without sufficient support in those sites locally in terms of understanding what needed to be done. And that really led to this initiative with ASCO and Barrett Health in Montana, as well as Bozeman Health. And this is, we've now been funded as part of a multi-year pilot program to increase high quality and equitable cancer care at this site in rural Montana. And the work in this area was based on, again, the prior work on the task force that Dr. Prakash talked about in terms of identifying what barriers were in place to getting care to patients in their own community and how we could overcome these barriers. And really the concept of this program is to enable patients to receive care in their own community through what's described as a hub and spoke care delivery model. And this is an established method for extending access to cancer care in remote rural areas. In fact, I think as Dr. Sabazin talked about, I think much of the work, published work in this area has actually come out of Australia. So again, kudos again to that health system in terms of taking the initiative on these things. And the initiative that we were talking about aims, again, to keep patients in their own community for as much of their cancer care as feasible, not to rely on that long drive to our regional site to get care. We understand this will require education and training of primary care physicians, advanced practice providers, pharmacists, and nurses at what we would refer to as the spoke site. And specifically, this needs to focus on education regarding how to properly administer infusion services, and also how do we provide adequate supportive care for the cancer patients. We do appreciate that those providers at that distant site, we can never really expect them to have full knowledge to appreciate what treatment cancer patients will need at any given point in time. But that really is where the expertise of the oncologist comes in. And oversight from the hub site will be provided by oncologists, both by telehealth and supplemented by regularly scheduled on-site visits by the oncologist to ensure just a seamless integration of care at both the hub and the spoke site, and also to ensure a shared culture of cancer care between those two sites. So that is the intent of the pilot that we're setting up. As we achieve function of that site, we will be doing quality measures to ensure that the care that's being administered at the spoke is really equivalent to what they would be receiving at the hub. So hopefully this will become a model for how we can deliver care to more remote rural areas in this country. I'd like to give Dr. Sabazin and Dr. Prakash an opportunity to make further comments regarding that model, and any suggestions they may have, I'm willing to take in terms of how we can achieve this end.
Yeah, thank you, Jack. And again, kudos to you for being so passionate about taking care of patients in rural areas, with their cancer care. But I think you highlighted the most important thing. We got to be passionate. We got to care. We have to do everything possible, find solutions. There are many challenges in this realm. So the hub and spoke model, that's very helpful. But again, we may need more multi-hub models or regional hubs, so to say, on that. Education, keep developing workforce, retain the workforce that we have, provide access to research, promote telehealth as much as possible. I think these are all pieces to the puzzle. Keep doing advocacy and just work and hopefully not get burnt out. So, yeah, I mean, it's a work in progress. But again, that's why I'm doing this, because I'm passionate about this. And thank you so much for having me as a part of this conversation.
Well, thank you for participating. Sabe, any comments?
Yeah, thank you. I really enjoyed being part of this conversation. And I think it looks like it's almost good to have a community of international rural practice like this, so that we can share and implement within our sector. And I'm really looking forward to see how your pilot project evolves, Jack, and how that can become a model for the whole of the country. Good luck to you.
Thank you very much for that. And again, just the comment about the international working on this, we do have someone from Romania on our current task force. There's a group there that's very interested in providing kind of hub and spoke model care. So these are topics that I think are really getting on everyone's radar internationally. Again, I think the more buy-in we get internationally as well as nationally, the more wind we will have at our backs in making some improvements in this. Thank you, Dr. Prakash, for your insight into this topic, and also to Professor Sabazin for his perspective from his practice in Australia. I'm Dr. Hensold, and I would like to thank all of our listeners of Cancer Topics and ASCO Education podcast. This is where we explore topics ranging from implementing new cancer treatments and improving patient care to oncologist well-being and professional development. If you have an idea for a topic or a guest you'd like to hear on the show, please email us at education@asco.org. To stay up to date with the latest episodes and explore other educational content, visit education.asco.org.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.